Thank you for joining us today for our Understanding Oral Allergy Syndrome, Pollen Food Syndrome webinar. I am Jennifer Gertz, Executive Director of Food Allergy Canada, and our guest speaker today is Dr. Ellis. Before we get started, just a couple of housekeeping notes. Please note that this session is for informational purposes only and will not provide specific medical advice, recommendations, diagnosis, or treatment. Please talk to your doctor about any concerns or questions you may have regarding your own health or the health of your child. All participants are muted so we can keep the audio clear for the webinar, and this webinar will be recorded and shared on foodallergycanada.ca afterwards. We're delighted to have Dr. Ellis join us today to share her expertise on this subject of oral allergy syndrome, a topic that generated an awful lot of interest from our audience, and we'd like to thank everyone for submitting their questions in advance on registration. So here's how the session today is going to work. We've broken the content into 3 sections. The first is around what is oral allergy syndrome under the umbrella of food allergy and a bit of the science behind it. The second section will then be on symptoms and diagnosis, and then the last section on management and treatment. Dr. Ellis will cover each of these sections, and then we're going to stop to address many of the common questions we received from you on registration. That said, if you do have additional questions during the session, please submit them in the chat question box throughout the webinar, and we'll try to get to as many of those questions as we can in the time we have available. Now, before I turn it over to and officially introduce Dr. Ellis, let's get a sense of who's joined us today in our viewing audience. So we have a quick poll that we'd like to put up and we would like to have you answer. So please identify yourself in one of the following ways. I have a child, or I have oral allergy syndrome. I think I have, or I think my child may have oral allergy syndrome. I support patients with oral allergy syndrome, and I support individuals managing oral allergy syndromes. So let's just give a couple of seconds there for people to quickly complete the poll. So we've got the results. Half the audience is either has or has a child with OAS. There's a portion of the audience that believes they may have OAS, and then we've got some people who are supporting patients or individuals. Thank you very much for giving us a sense of who's joined us today. Now, I'm going to ask Dr. Ellis, and I'm going to do the same. We're going to turn on our webcams, and then I'll introduce Dr. Ellis and turn it over to her for the introductory section. So, Dr. Ellis is a professor of medicine and chair of the Division of Allergy and Immunology at Queen's University, and holds the James H. Day Chair in Allergic Disease and Allergic Research. She is also the director of the Environmental Exposure Unit and the Allergy Research Unit at Kingston General Hospital, the vice president of the Canadian Society of Allergy and Clinical Immunology, and she also serves for the Joint Task Force for Practice Parameters, which represents the American Academy of Allergy, Asthma, and Immunology, as well as the American College of Allergy, Asthma, and Immunology. So you can see with those many accomplishments and those many responsibilities, we have quite the expert who has made some time for us today to share her expertise on oral allergy syndrome. Dr. Ellis, I'll turn it over to you.
Great, thank you very much for that kind introduction. As always, whenever I give a presentation, I give my disclosures. I do research for a living, particularly I run a lot of clinical trials, so that does lead to a lot of funds coming to our institution. It doesn't come to me personally, and just as a point of order, today's webinar there's no honorarium associated with this one. It's supported entirely by Food Allergy Canada. So thank you, and we can move on to get started. So we're going to be covering what do we mean by food allergy versus other types of adverse reactions to food. We're obviously going to talk about what is oral allergy syndrome, or more recently it's being dubbed pollen food syndrome, and we'll talk about why that change in language has occurred. We'll go through the symptoms and how you make the diagnosis, and obviously we'll help you understand how to manage your symptoms and what are appropriate treatments to consider. So what does food allergy really mean? So people can have adverse reactions to food, and that doesn't mean that they're allergic to it. So it's important to recognize that you can have an abnormal reaction to a food that can be toxic. So for example, you've got food poisoning, for example, when there's bacterial endotoxins in the food that you just ate and you get nausea, vomiting, diarrhea, and feel really miserable. And there's non-toxic reactions to foods. So we can have immune-mediated food allergy, and we're going to be talking about an example of food allergy today in pollen food syndrome. But a lot of people also have food intolerance, which doesn't involve any immune mechanisms. People just don't feel well when they eat a certain food, but they're not actually allergic to it. So when we say food allergy, we mean this is the IG, typically it's one of 3 different pathways we use involving the immune system. The most common is the so-called IgE-mediated food allergy, which is what can trigger, for some people, severe symptoms like anaphylaxis. But this oral allergy syndrome is also IgE-mediated, but obviously doesn't have that same severity as one expects from anaphylaxis. There are patients who have a mixed IgE-mediated and non-IgE-mediated food allergy issue, and a classic example of that is eosinophilic esophagitis. A lot of people with eosinophilic esophagitis, and again, that's just driven by having too many eosinophils literally in your esophagus or what your swallowing tube. And a lot of those patients have the inability to eat certain foods, but it's not always due to an actual allergy, or sometimes it can be. So there can be a bit of a mixed picture there. And then we definitely see, not commonly, but we do see it in children, particularly a non-IgE mediated food allergy, where it's driven by a cellular reaction. So the cellular arm of your immune system can induce something called FPIES, which stands for food protein induced enterocolitis, where children present with severe vomiting, bloody diarrhea after the ingestion of a certain specific food. One of the reasons why we say this isn't quite as common is because, for one thing, it's often outgrown and doesn't last into adulthood, whereas a lot of food allergies do tend to last a lifetime. It's important to recognize how many different food intolerances are out there. So again, intolerance is not an allergy. So when somebody says they're lactose intolerant, they're not allergic to lactose. They lack the enzyme lactase, so they feel abdominal bloating, nausea, vomiting if they eat milk or anything else that contains lactose. People can have pharmacologic sensitivity, so feel jittery and unwell, for example, if they take caffeine. And then there's also obviously just, I can't stand the smell of eggs, for example, and that's a psychologic or a food aversion. So you avoid the food because you don't like it or what have you. So it's just important, if you're saying that I'm allergic to something, it's important to recognize what's actually IgE mediated and what can put you at risk for anaphylaxis, as opposed to a lot of these other things that don't carry that same risk. So again, this is a lot of immunology at lunch is sometimes hard to digest, but just to walk you through a little bit about what happens. So first, what happens is you have to become sensitized to something to form these IgE antibodies to whatever it is you become allergic to. Those antibodies find their way to the surface of a mast cell, and that's where they live. And when they come across the allergen again, this leads to what we call cross-linking of these IgE molecules, which as a result sets apart this pathway of mast cell degranulation, where they release all kinds of mediators, including histamine, platelet activating factor, and a myriad of others that have a lot of vasoactive effects on blood vessels, smooth muscles, and the lung, intestine, and skin, leading to the symptoms we see. So again, it's important to recognize that you have to have seen something first to become sensitized to it before you can develop an actual allergy to it. So the pathway, that mast cell degranulation is very immediate. So usually within 15 minutes of exposure to the allergen, the symptoms will start. There's occasional examples where this could be more delayed, but the vast majority, it's right away and definitely within an hour of exposure to the allergen. So what are we talking about with this oral allergy syndrome? So as I mentioned, you have to start everything off with sensitization. So at some point, people can become sensitized to various environmental allergens like birch pollen, grass pollen, and usually all that does is lead to symptoms of hay fever. This is the time of year when we're seeing this all the time. People are starting to get runny nose, stuffiness, itchy, watery eyes, because we are now just heading into the beginning of birch pollen season. The people who have birch pollen sensitization, for example, can then develop a secondary problem due to their birch allergy, where you get itching of the mouth and throat after you eat certain fresh fruits and vegetables. And in fact, it can happen quite commonly, particularly in people who are sensitized to birch tree pollen. Up to 75% of adults with birch allergy have symptoms of this oral allergy syndrome. And the reason why this happens is because there are shared proteins. We call them plant defense proteins that the birch allergen has, and that the fresh fruits and vegetables have as well. as I say, it ends up being a sort of a cross reaction because you've got something that naturally defends off the, things like insects, for example. These are proteins that help the plants and vegetables defend themselves. So they are very similar in the way they look to that IgE molecule. And therefore you can get a cross reaction from these fresh fruits and vegetables as a result of your initial birch or other pollen sensitization. So we've termed this oral allergy syndrome. We occasionally will refer to it as pollen food syndrome because we recognize that sometimes you get symptoms that just aren't within the mouth. So, and if we go on to the next slide. So again, you can think of this, and one of the reasons why it's so easy to sort of distinguish whether or not this is oral allergy syndrome versus a more severe food allergy is because once these cross-reactive proteins are what we call heat labile. So if you cook them or process them, you flatten the protein and the antibodies can't bind anymore because the shape of the proteins that those antibodies want to bind to has now changed. So it can bind to it if the fruit or vegetable, for example, is in a raw form. But once you cook the apple and make applesauce, or you cook the carrot, you flatten the proteins, and then that antibody just can't make that connection anymore. So what are the sort of common cross-reactors? So as I mentioned, birch is one of the most common culprits in this circumstance. That's why we've listed it first. Really, any pitted fruit is at risk for this type of cross-reactivity. Very commonly, I do see the cherries, the apples are sort of top the list. Kiwis, very common. Also carrots and celery, I see extremely commonly, but you can see we've made a nice list here for you, and we have another image on the next slide to go through these. This occasionally happens with grass pollen, nowhere near as often as with birch and ragweed. So ragweed, I see a lot of patients who have these cross reactions with banana, melons, and cucumber. But by far and above, the most common is you're allergic to birch because you can see the list is quite large of the possible things that birch pollen can cross react with. And importantly, you might pick out the fact that we've got some tree nuts in this list, which can definitely lead to a little bit of confusion about the diagnosis of, do I have a tree nut allergy that's going to put me at risk for anaphylaxis, or do I just have oral allergy syndrome? So, and it's important to recognize that tree nuts and occasionally peanut can cause oral allergy syndrome or pollen food syndromes in these birch sensitized patients, and hazelnut is the one I see most commonly. But it's important to recognize that your symptoms will always be that itching of the mouth or throat and in that mild category, and you're not at risk for anaphylaxis. And we'll talk about how you can tell which one category you fall in and when we get into diagnosis and management. But it is important to recognize that this cross-reactivity can happen with tree nuts in addition to the fresh fruits and vegetables.
Okay, great. Well, thank you, Dr. Ellis. So we're going to take a bit of a stop right now, and we're going to address some questions. I just want to make sure I'm going to kind of do a review of what you've stated, and please make sure if I've inaccurately stated that, then you'll let me know. So we're talking about the way that this develops is first you become sensitized to kind of an aeroallergen, commonly birch. That then turns into hay fever. So you actually have the allergy. You've gone from sensitized to the allergy. And then there is this possibility that you can cross-react when you eat raw fruits and vegetables that have proteins that look very similar to those of the pollens. Is that in essence what's happening?
That's a really good summary of how this occurs. Very rarely I will see people who adamantly deny having any symptoms of hay fever, but their symptoms and signs that go along with oral allergy syndrome are highly consistent. And sure enough, when I skin test them, well, there's a sensitization to the birch. So, but I've seen that many times, but it's much more common that you get the symptoms of seasonal allergies. And the symptoms of seasonal allergies can actually be quite mild and still manifest into this oral allergy syndrome.
Okay. So now let's just, you mentioned that birch is the most common and that it's a number of adults, I don't know, 75% of adults have with birch allergy are potentially affected by OAS. What do we really know about the prevalence of, and I'm going to call it OAS just because it's a little bit easier to kind of have that roll off my tongue at this point in time. But what do we know about the prevalence and really how does it develop? Is this an adult issue, or is this a childhood issue? Tell us a little bit about prevalence and when it develops.
Yeah, it tends to onset a little bit later. I mean, I do see it in children, but more commonly it takes a little bit of time of actually getting into a couple of hay fever seasons for this to develop. So the most common onset that I see in my practice is in your early 20s kind of thing. In terms of the actual prevalence, we don't have good data. It's something that we really do need to delve into a little bit better. Again, the studies that I looked at to come up with these slides, that ranged from 30 to 75%. And that's why I said up to.
Okay.
But it's something that we still don't, other than the fact that it seems like it's increasing, again, based on anecdotal evidence from what I see in my clinical practice, it's definitely common and it seems to be increasing, but we don't have good numbers.
Okay, and do we know anything about whether it can resolve over time? Or do you see patients who have OAS and then later in life it's been resolved? Does that happen?
Not as often as I see people who have intermittent symptoms. So they'll only get their symptoms at some times of the year, or there's seems to be something with this particular fruit compared to that particular fruit that their symptoms sort of come and go. And the people I've seen where it actually resolves, though, has been as a result of interventions that we'll be talking about later.
Okay, perfect. Okay, well, listen, we're going to go back to the slides because I think a lot of people in our audience want to hear about signs and symptoms and diagnosis. So these next two sections will be extremely helpful for folks.
Thanks.
So back to you, Dr. Ellis.
So the very common manifestations are itching of the mouth, itching of the throat, the tongue, the roof of the mouth, lip tingling, occasionally mild lip swelling or mild tongue swelling can occur. As I mentioned, some patients go on to have one of the reasons why we're trying to call it pollen food syndrome is because not all the symptoms are always just in the mouth. We have mast cells throughout our entire GI tract, so some patients may develop nausea, vomiting, abdominal pain, particularly if a large amount of the culprit food is consumed. But again, as I mentioned earlier, they don't happen if you eat it in a cooked or processed form, and a lot of patients haven't thought to try that. So that's something that I do specifically ask about anytime somebody comes in with a history of, I get itchy throat and itchy mouth every time I eat apples. I go through certain questions about what about applesauce, what about apple pie? So again, sometimes it's hard to do that because there's certain fresh fruits that you would never cook. But that type of symptom can really help you feel confident that this is OAS as opposed to something more sinister. Very, very rarely, we can see more severe throat swelling leading to difficulty swallowing or breathing, but it's a real small minority of patients with OAS who are actually at risk for having anaphylaxis and needing to carry an epinephrine autoinjector. So I can't say it's zero, but it's quite low. So one of the ways that you can help try to tease out which sensitization you may have before you have a chance to see an allergist is I've put up this typical map of the pollen seasons across the country. The symptoms that you experience from oral allergy syndrome will happen any time of the year. Some people do notice that their symptoms are worse if they're eating the culprit food at the time that their hay fever is active. So if you're eating raw carrots, for example, in May, when there's lots of birch pollen around, you may find that the symptoms are worse than if you just had it in the middle of winter. There have been changes to our pollen seasons. This graph is from 2001, but it's just such a nice image and it's mostly accurate. We don't really see tree pollen in Ontario much anymore in March. We don't see grass yet in April very much in Ontario anymore. And again, it's important to recognize that the only sample there for Ontario was in Windsor. So that could be why some of these seasons look to happen more similar to what you see in British Columbia, where things happen a little bit earlier in the year. So, but typically early spring is tree, late spring to early summer is grass, and ragweed comes in areas that actually have ragweed pollen. So you lucky Westerners don't even have ragweed. Comes almost in Kingston anyway. It starts, so you can set your clock to it practically. August 15th every year is the start of ragweed season. It has been for the past 10 years and goes through to early October or whenever the first really good frost happens to be. So in terms of how do we make the diagnosis, often I can just make it from history alone. I hear the story, it's so consistent, it's so classic. Obviously though, it's nice to have the confirmatory skin test, and I do encourage everyone to see a board certified allergist to make sure that the skin testing procedure that you undergo if you're a patient is an appropriate one. It's not being overcalled or undercalled in terms of positivity or negativity. There's definitely discrepancies that I've noticed in my practice over the years when I have people who have come to me from somebody who was their allergist and retired. You look that person up and they're not actually allergists. They're a primary care provider who took a weekend course in skin testing and calls himself an allergist. So it does make a difference if you see somebody who actually has Royal College training in allergy and immunology, if you want to get access to a really good diagnosis. We also have the ability to order specialized blood tests to confirm what those people who have the tree nut cross-reactivity. We can order tests that actually figure out what little bits of the hazelnut are you actually allergic to. Is it the little bits that's identical to birch pollen, or is it the little bits that mean, oh, you could have a systemic reaction? So I recognize we have an audience that's across the country. In Ontario, those tests are not paid for by the government, so they do cost you as a patient money to access unless your allergist happens to be based in a hospital like I am. And so far, the hospital is covering it for my patients. Who knows, that may change down the line. In other provinces, it is free and it is covered by the government, so it's something you can just ask about. But again, you want to make sure that if you're ordering blood tests around food allergy, you want an allergist to help you interpret that, because you can't make a diagnosis of anything on a blood test alone. And I'm sure you've been coming to Food Allergy Canada webinars for many years. You'll know that we don't make a diagnosis based on a skin test alone or a blood test alone. We need it paired with a history that fits. Obviously, the gold standard would be to give you the food in my clinic and we watch and see what happens. That's obviously something that you only do in a supervised environment. And again, you'd only want an allergist doing that for you. If you were really worried that you're one of those tree nut reactors who wants to know for sure, is this, am I at risk for anaphylaxis, or am I just going to get local symptoms? The way you know 100% for sure is to do an oral challenge in an office setting. So you probably just, some people are sort of blown by the fact that there's all kinds of people out there calling themselves allergists, and then you find out, oh, they're not. They just do skin testing. So how do you know if you're seeing a real allergist? Well, fortunately, our Canadian Society of Allergy and Clinical Immunology, or CSACI for short, has an app for that. So you can go right to our website. It's up at the very top of the screen, and you just click on that Find an Allergist, and you type in the city you're in and the range you're willing to travel and kilometers, and it'll give you a listing of people who are actually members of our society and board certified.
Excellent. So we're going to move to some questions, and we've had a lot coming in on the chat box, of which some of them we're going to get to in this section and some of them we'll get to in the next section. But there's lots of questions, lots of interest on this topic. So let's just go through a bit of a review, because I think this is one of the kind of the key takeaways around the typical signs and symptoms of OAS, and how do you differentiate that versus what is anaphylaxis? Okay, so if you can walk us through just a quick review of that again.
Right. So OAS symptoms are going to be localized to usually the mouth and palate, occasionally the GI tract, but just that basically mouth to anus, if you want to picture it that way. That's where those symptoms will manifest if you have OAS. If you have an allergy that puts you at risk for anaphylaxis, or you have had symptoms like I'm about to say, then that's a different kettle of fish. So breaking out into hives over your entire body, severe swelling of the mouth, tongue, coupled with difficulty breathing, wheezing issues, feeling dizzy, loss of consciousness. Again, anaphylaxis is multiple organ systems that is more severe in nature, whereas OAS, it sticks to the whole oral area, and again, sometimes can involve the GI. Sometimes there can be fairly pronounced lip swelling, and sometimes there's periorbital swelling around the mouth, particularly if you're eating the raw fruit in season. But again, that typical history of, but I can eat it cooked, that won't happen. Okay. So if you're at risk of anaphylaxis, you will have symptoms even when it's been cooked to death.
Got it. Okay. Now, what about sores in your mouth? Because sometimes when you eat fruits and vegetables, you can get sores in your mouth. Is that an indication of OAS?
So it can be on occasion. It's not as common as just the itching and the discomfort. Again, it's one of those things that it's difficult. It's not one of these things where you can say never or always, because I have seen people where that again, that history of what happens when you eat it when it's cooked is so helpful. But again, sores in the mouth are common with a lot of fresh fruits because they're acidic. So, you see mouth irritation from pineapple, for example, just because of the enzymes that's in the pineapple. Similarly, spinach can give everybody sort of a tingly, itchy, uncomfortable feeling, depending on, again, that sort of gets more into the intolerance side of things. So again, trying it when it's cooked or processed makes a big difference to help sort that out. But blistering, while I've seen it, is not as common as all the other symptoms I've described.
Okay. Okay. Now, so there's some people in our audience that think they have OAS. Okay. And there's probably some people who maybe haven't got a formal diagnosis. When is it that you would recommend, and this is a question actually that came in from both individuals, but also healthcare providers. When is it that you would recommend someone proceed with a formal diagnosis and take that step to find that certified allergist to get clarity?
Yeah, I think if symptoms are particularly bothersome and you're starting to get them with multiple fruits, I mean, I think it'll help be reassuring to you to know that, yes, I can reassure you based on my testing and my history that this is just OAS. You're not really, like, if you're anxious that this is going to put you at risk for anaphylaxis, by all means, come see us and we'll help you sort it out. If you've done your own oral challenge and you can't eat a raw apple, but you can eat applesauce, and it doesn't bother you and you're happy just to avoid raw apples for the rest of your life, you don't need to come see me. But definitely anybody who's got any degree of anxiety around it, and I think definitely for the tree nut people, right? Because you don't want to avoid a whole family of really healthy protein sources that's got lots of great nutrients in it if you don't have to. So having peanuts and tree nuts in your diet has lots of benefits. So if you are truly allergic and at risk for anaphylaxis, then obviously something you're going to avoid. But if there's any uncertainty, that's worth finding out for sure. And it's really liberalizing for people who have been really afraid that they're going to die if they eat hazelnut. And then I do the testing. I'm like, no, you're not. And then we do an oral challenge to prove it, often just to help reassure everybody. And they're like, wow, this is crazy. This is something that I've been avoiding and terrified of, may contain traces for years. So it's really helpful, particularly if you're a tree nut peanut person and you're not sure.
Okay, so let's assume someone is a tree nut peanut person. They're coming to your office. They have this concern around oral allergy syndrome. Walk us through what the diagnosis process looks like. And I recognize that, you said that component tests don't exist everywhere, but, maybe walk us through exactly what that's going to look like.
Yeah, so I take a detailed history. What are the exact symptoms you've experienced in the past? Do you have hay fever symptoms? And if you do, at what times of the year? And then I probe to make sure, like, even mild symptoms can result in these cross reactions from happening. The skin testing becomes important because if we see a positive test to birch and a trivially just barely positive test to one of the tree nuts, then I'm already sort of leaning in that direction. But again, ultimately the component testing is really helpful because I can figure out which part of peanut are you actually allergic to, which part of hazelnut are you actually allergic to. But failing that, if I were in an area where you couldn't access the test or it was you couldn't afford it, then try to find somebody who's willing to do a supervised oral challenge, who can treat severe symptoms if they happen. And I've done that on occasion for the tree nuts, for example, where I can't get it. So almond is an example of a tree nut where we don't have the components yet. So I end up doing oral challenges to almond in my office. And if all they ever get is mouth itching, then we'll see how many you can eat. And they're like, well, you just now ate 6 almonds and all you have is a little bit of mouth itch. I'm not worried.
Right. Now you do have patients that have both OAS, but also might have a food allergy to something that's not OAS related. They can focus. Yeah. Okay. Now, the other thing and this is a question that came in from some of our dietitians that we're watching, is that, they have some OAS patients who have, got identified one pollen and one food. But how do you assess the other foods in that pollen category? Like when we looked at birch, there's just all those pitted fruits in there. But how do you, as someone who's a healthcare provider, kind of give guidance on, okay, if it, what do we think about when we know that there's one food that's a trigger?
So again, so lots of people have only one food. Just because you have OAS due to birch doesn't mean you're ultimately going to react to all those other foods. And again, the gold standard is what happens when you eat it. So if somebody's not having any symptoms when they eat raw apples, for example, but they have symptoms when they eat raw carrots, I'm like, go ahead and keep eating your raw apples. And I don't stop people from eating foods within that food family if they're not having symptoms from them. So I think it's important to recognize that there's people who, yes, every single pitted fruit, they get the symptoms, and so they can't eat those. But there's lots of people who just have one. So.
Okay. Now, on progression of reactions on re-exposure. So there is some belief that exists in the community around, okay, if I eat this once and I have a reaction, that when I eat it the next time, the reactions become more severe. Is
So again,
that?
Yeah, it's a similar phenomenon to what we see with the types of food allergies that you get questions about all the time. So the severity of your initial reaction doesn't necessarily predict the severity of subsequent reactions. The next one could be milder, it could be identical. Yes, it could be more severe, but typically for oral allergy syndrome, it doesn't progress. It's not this, and that's, I mean, I never say never and I never say always. We're in medicine after all, and it's the immune system on top of that. But typically, the symptoms don't progress.
Okay. Now, one more question before we go on to the next section, because we've got some other things we obviously want to cover off. There's been some questions that have come up around the degree of processing, okay, that makes that changes the protein and can make it then consumable. So, is there a stage at what is considered cooked, and is there aside from heat, is there other food processing approaches that can change the protein structure?
Yeah, and we do have that as the ways, and was one of the management strategies. But everybody's different. So for some people, even just a quick blanch is enough to, and again, it depends on your degree of sensitivity, right? For some people, a quick blanch is enough. Other people, it's got to be cooked to death. So everyone's different, unfortunately. But I have people who, for example, all they have to do is peel the fruit, and that's good enough because there's a higher concentration of these cross-reactive proteins in the peel. Again, they're defense proteins. That's the outside of the fruit that they're trying to defend off, right? So the best is obviously heavily cooked or fully processed, like canned.
Right.
But obviously, the more you cook it, the less you have the nutritional benefit. To my dietitians, I already know that. But that is, unfortunately, there's no magic answer. It's not like when you're talking about a baked egg challenge where you say cook them up in a 350 degrees Celsius for a full hour, and then I know it's clearly baked enough for a baked egg challenge. For this, it's a little bit more due to the person's individual sensitivity.
Okay. Now, what about dose? Is dose factor into the size of the reaction or the degree of the reaction?
Absolutely, yeah. I've seen people where they can eat 1 or 2 almonds. If they eat a whole handful, then they get these uncomfortable symptoms.
Okay. Okay. Let's go back to the next section that's on management and treatment. And I know we covered a little bit of that off right now, but walk us through this next section and then we'll go back to some final questions.
Yeah, so there's lots of options for trying to deal with these symptoms. The easiest is just don't eat it, but lots of people still want to have some of these fruits and vegetables in their diet, and quite rightly. So again, cooking it or heating it up, again, changes that protein composition. It flattens the proteins, and many times that's all you need to do to make the symptoms go completely away. Again, the ultimate processing is canned fruits and vegetables, and usually that's almost never reactive to anybody now who reacts to oral peaches, for example. Canned peaches can almost argue it's practically like a different fruit if you enjoy both of them. But that certainly seems to work. And as I mentioned, though, I've got some patients who just have a milder form, and all they have to do is peel, particularly apples. Just don't eat the peel, and that can be enough to take away the symptoms. And again, I think the other thing to recognize is that if you don't have to include in your management strict label reading, right? So if this is something that these are the good thing about fresh fruits and vegetables is they're never going to be in trace amounts in anything, and if they are, they're not likely going to cause symptoms because there is this dose threshold issue. So that's something that can be reassuring for people as well. So we do have other treatment strategies, and I have a number of patients who do this. They can get away with taking an antihistamine about an hour prior to eating the food, or some people just choose, I'm going to be taking antihistamines anyway through the season, and I notice that when I'm actually adherent to that and I take it every single day, I don't get these food reactions anymore. So that's a possible strategy for some people. And again, We do want to make sure that people are using second generation antihistamines, not the older sedating antihistamines, and I'll discuss why. It's a combination of these are actually more effective in addition to having a much better safety profile. But I also treat some patients with immunotherapy, and the data around this is from the injectable type of immunotherapy, or so-called allergy shots. And I have had success in eliminating oral allergy syndrome symptoms in people that I've treated with immunotherapy to manage their allergic rhinitis, but you get the benefit of also treating their OAS. So again, why are we emphasizing using second generation? What's wrong with Benadryl? Well, so the CSACI has we've been railing against Benadryl for decades. So we finally put some words behind our complaining and published our position statement, really underscoring why we don't need to use first generation agents anymore. So they're the ones that are associated with sedation. They impair and decrease cognitive function. They actually, ironically, lead to poor sleep quality. So lots of people say, I like to take a Benadryl at bedtime because then I can sleep. But actually, it's non-restorative sleep and you lose the REM sleep. So you don't get any dreams if you take a Benadryl. You've actually just sedated yourself. You aren't encouraging a good restful sleep. And they're associated with dizziness and feeling dizzy when you stand up. And there's also been problems with deaths from the use of sedating antihistamines, either because of accidents, because psychomotor performance is impaired when you're driving, overdoses, and are associated with sudden cardiac death. So when we have that huge list of second generation agents available to us that I showed in the previous slide, you don't need to be using these older antihistamines that never would have passed FDA regulations had they been brought to the market after the FDA was invented. So again, they've been around for so long, they've been what we call grandfathered. So they never had to go through a rigorous randomized controlled trial process to prove they're safe and effective. And in fact, if you look at the side effect profile of something like Benadryl, we would not have it on the market if it were trying to be launched today. So again, this is just a nice infographic that shows you the myriad of side effects that first generation antihistamines can cause. I already talked about the impairment of alertness, impaired learning and memory formation. I really stress this for children because if it impairs learning, that's not a good time to be taking sedating antihistamines. And the impairment occurs even if you don't feel sedated. So they've done good driving studies where the patients also report their how sleepy they feel on a standardized scale. And they don't drive as well as the people who are on placebo, despite saying, I don't feel tired. So you don't have to feel sedated to be impaired. They cross-react with a type of receptor called a muscarinic receptor, which leads to dry mouth and urinary retention. They can cross-react with serotonin receptors, which lead to increased appetite and weight gain, particularly with prolonged use. As I mentioned, they can cause dizziness, and they can interact with cardiac ion channels. So ion channels in your heart leading to arrhythmias and sudden cardiac death. So lots of reasons to stay away from those older antihistamines. So in summary, I hope I've convinced you that this is a common condition. I can't tell you exact numbers because we don't really have good prevalence data, but it's definitely common. This is something that is a result of cross-reactivity between shared plant defense proteins in pollens, fresh fruits and vegetables, and in some cases, peanut and tree nuts. It's really important to see an allergist with access to component testing or the ability to do oral food challenge to get your solid diagnosis, particularly if you're somebody who gets itching of the mouth and throat with tree nuts, for example. And management includes a combination of either avoiding the food, consuming modified version of the foods, it's occasionally antihistamines or immunotherapy. And as a general rule, you don't need to carry an epinephrine auto-injector for oral allergy syndrome.
All right, great. Okay, so the chat box has been busy. We've got lots of questions. So the great news is we've got a good amount of time to go through many of those questions. So let's get started. So let's go back to the topic of avoidance of the OAS trigger foods. So when is the like there's not exactly one statement around should the problem foods always be avoided. Just restate the statements around kind of when it should always be avoided and when you would consider recommending to someone, no, it can be consumed in its raw form.
Yeah, so it really comes down to how bad are the symptoms? How bothersome are they? If you don't mind a little bit of mouth itching and that's all you get, then go ahead and eat it if you really enjoy that fresh fruit or vegetable. again, when symptoms are intolerable and really uncomfortable, or if you're one of the patients who gets the nausea, vomiting, abdominal pain, diarrhea, you're probably going to want to just always avoid that. You get to the point where you remember feeling so uncomfortable the last time you ate it that you have no interest in eating that now, and you don't even want to try a can, for example. So that's sort of really how you make the decision point about, do I completely avoid this? It really comes down to how bothersome are your symptoms.
Okay, now what if you have a diagnosed food allergy and OAS? Does that change the avoidance piece, or are the two kind of completely separated?
They're separate issues, right? So if you've got a diagnosed food allergy where you have been told you're at risk for anaphylaxis, obviously you're just going to avoid that food. But OAS doesn't mean that it doesn't progress because you keep eating the culprit food. So it is a different type of food allergy, and it is managed differently. So the types of strategies like taking an antihistamine before you eat it, I wouldn't make that recommendation for somebody with a diagnosed shellfish allergy, for example, where they've had anaphylaxis in the past. I'm not going to say, oh, just take an antihistamine before you eat shrimp, because it doesn't work that way. But for OAS, it's managed differently. It's a different problem. It's a different type of food allergy altogether.
Right. Okay. So if I have OAS, but I also have a food allergy, I don't necessarily have to avoid the triggering food on OAS. It depends on what symptoms I have for OAS.
Correct.
Okay,
Yeah.
got it. Okay, now in terms of the form, or the cooking versus raw, we've had some other questions around kind of the processing, and one of them is freezing. Does freezing change the protein structure, or is it only heat?
That's a really good question. I would actually have to do a quick literature search to find out for sure, but I have a feeling that freezing doesn't do it. Otherwise, we'd have people who can tolerate more smoothies and things like that, which is usually made from frozen blueberries or something like that, for example. But I can do a quick lit search and get back to you, and that can be fed back through the Food Allergy Canada channels.
Perfect. Okay.
But classically, it's cooking and heating that definitely flattens the proteins.
Okay. Now, what about, I guess this one might be hard to ask. It might require going to the manufacturer, but when we think about nut milks, and there is a lot more nut milks that are available, does that change the protein structure?
I would think so, because anything that's processed like that has to go through a pasteurization processing that usually involves a large degree of heat. It might be different though if you're getting something from, like, in Kingston here, Terra Natural Foods, or something that's come from a creamery, or something that's a little bit more closer to the source.
Okay.
So I think that would be something where, again, it's something that's on the grocery store shelf and is mass marketed. Chances are those would be fine. The way to know for sure is to make sure the first time you drink it, obviously take a very small sip, and if you get an itchy mouth, then don't drink the whole glass.
Right.
That
Right.
sort of thing.
Okay. Now, the trigger foods for OAS during pollen season, why is it that some people will experience worse symptoms in pollen season? What's actually happening there?
So your immune system's already activated because you're having symptoms of your allergic rhinitis. And we know that that actually can be a risk factor for regular food allergies, right? If your asthma is not well controlled, or so everything's sort of heightened because you've got more allergic inflammation at the time. So we think that's why symptoms can be worse in the height of the season, because you're being exposed to more of your primary allergen as well. Again, not everybody gets that seasonal worsening. It's just very clearly documented that it does, and just similar to sometimes skin test sizes can be bigger in season as opposed to out of season for that same reason.
Okay. Now, can OAS reactions include honey?
So it's been described with local honey that's actually contaminated with pollen. So it's not that it's the honey itself that people are reacting to, it's the fact that there's still some residual tree pollen in the honey.
Okay.
And by the way, eating local honey tastes good, but does not treat your allergic rhinitis.
Okay. Now, when it comes, I guess you've been asked that question a few too many times when you're wearing your allergic rhinitis hat. When it comes to grass allergy, is there any reason to avoid grains?
So no, again, it's important to only avoid things that actually give you symptoms. And
Okay.
again, that's the gold standard of, do I need to avoid this food? Do I get symptoms when I eat it, is how you would decide the answer to that question. And I don't see that a lot at all, actually. Grass, for whatever reason, their defense proteins must not be as aggressive as the ones that are in birch, because I don't see anywhere near as much of the culprit foods that have been associated with grass allergy as I do with birch and ragweed.
Okay. Now we're going to move on to some questions that are related to treatment. And first, we're going to talk about treatment of kind of symptoms, okay? Because we've had many questions again come up on Benadryl, okay, in the chat box around, what would you recommend for children, and are the second generation antihistamines fast acting?
Yeah, so they definitely are as fast acting. The reason why people think Benadryl is the fastest acting is because you feel the side effects before you actually get any antihistaminic effects. Especially if you're using the suspensions, so rupatadine, again, the prescription antihistamine comes in a suspension, and it's been studied in children as young as 2 in randomized controlled trials. Cetirizine, desloratadine, or Arius, and the first one, sorry, I should say, is Reactin. Claritin, all of these have liquid formulations that you can purchase over the counter. If you happen to have a drug plan, the Rupall suspension is usually covered by drug plans, so it saves you a little bit of out of pocket. But again, what I do is I make sure, even if you are old enough to take a tablet, if you're having immediate symptoms and you really want them to go away fast, then use the suspension, because that is more easily absorbed, because you don't have to break down the coating that's on the outside of the tablet. But all of the antihistamines that are available by prescription or over the counter have an onset of action of slower than 30 minutes, when Benadryl has not been shown to be faster than 30 minutes. We've always wondered why does this perception persist? Why does everybody think that Benadryl works faster? And we think it's because you get the side effects right away, and so you think it's doing something, and because it goes to the CNS almost immediately. So it does get that, cognitive impairments. It sort of makes you feel woozy, and it settles you down a little bit. We do know that Benadryl seems to have a calming effect because it's a sedative. So I think that's where some of this mythology of Benadryl works the fastest of anything.
Okay.
Granted, there are going to be some people who, for whatever reason, this antihistamine works better than the other antihistamine. So if one doesn't work, try another one. Don't give up on all of the second generations just because one of them didn't happen to work as well for you.
Okay. Now, a little bit more on the treatment front. We hear in food allergy, we've got oral immunotherapy that is kind of evolving in different parts of the country. Is oral immunotherapy something that can work to kind of lessen or cure oral allergy syndrome? Like, can you start eating little bits of the raw fruit and learn to tolerate it over time?
So no one's studying actual OIT for this. This as a way of therapy. There are published studies about how the subcutaneous immunotherapy can work and definitely works. And the difference is we target a lot higher concentration of the birch allergen in your injections as opposed to I would if I were just treating your hay fever. What's under development, however, and so stay tuned, is using the new sublingual tablets that are available for the treatment of hay fever, but using a slit tablet, particularly the tree one, which is the brand name is Atulitech. That's being actively studied to see if it will help treat pollen food syndrome specific to the birch cross-reactive plants and fruits and vegetables.
Okay, so but the one is for dealing with the aeroallergen, and then the other, that can you attack it from the food?
Right, so that's what's being studied.
Okay,
Yeah,
sorry.
we know that the birch tablet works to treat symptoms of birch-induced allergic rhinitis and conjunctivitis, or itchy, watery eyes. We know it works really well. What we don't know is whether or not it will work to treat OAS. But the question has been raised enough times that the company's actually moving forward with a clinical trial to specifically evaluate that.
Okay, but it's not like if I have OAS and the trigger food is raw apple, that by continuing to eat raw apple, I can develop a desensitization to raw apple.
No one studied that, unfortunately.
Okay. All right. Now, are there any other future therapies on the horizon? So we've got slit or the sublingual. I guess that's putting a pill underneath your tongue. Are there any other therapies that are being looked at for this condition?
Anything that treats birch allergy if they're successful in their treatment of birch allergy. So, for example, there's a number of different companies that are coming up with different ways to treat birch allergy with injections that are a totally different regimen than the traditional, weekly injections for 6 months, followed by monthly injections thereafter for 3 to 5 years. There's lots of sort of altered immunotherapy regimens that are being studied. And if they're successful against the treatment of hay fever-like symptoms from birch, every single company is going to then try it for oral allergy syndrome, because they do see this as such an unmet need.
Okay. Now, the other thing that we've had some questions coming in on is we've talked a lot about birch, but are maple trees, alder, which is like, is there a broader category of trees that are associated with oral allergy syndrome?
So there's a lot of trees that are what we call birch homologs. So they're they're all in the same family, and they're all very similar. So birch, alder, hazel tree, not surprisingly, given that we see this issue with hazelnuts, but also oak do have a fair bit of cross-reactivity. So whereas it doesn't seem to be an issue so much if you're just allergic to, say, willow, for example, or maple. There is something about the birch homologous families that must be, they're very resilient. They must make really strong defense proteins that seem to be more commonly associated as opposed to some of the other trees.
Okay. Now, another question back on the immunotherapy treatments. At what age can the allergy shots and that approach to immunotherapy start?
Yeah, so for children, we usually recommend waiting until the child is at least 5 years of age, so that we can feel confident that they can verbalize if they're having early symptoms of an allergic reaction. Again, one of the drawbacks to injectable immunotherapy is it carries a higher risk of anaphylaxis than the tablets. Whereas the tablets are now licensed for use in children 5 years of age and up for the grass tablets and the ragweed tablet. I'm actually running a clinical trial right now for the house dust mite tablet in the pediatric age group. So the others will follow over time. Some allergists are comfortable prescribing what we call as off-label. So we figure the grass and the ragweed, they're safe and effective. Chances are the tree will be as well. So that just depends on your comfort level as a parent and your doctor's comfort level, because every doctor's different about what they're willing to do outside of how much they want to color outside the lines, as you might want to say. But generally speaking, I wouldn't give immunotherapy injections until the child's at least 5 years of age. Having said that, there's not a lot of 5-year-olds who sign up either. So usually it's when they become teenagers and they're just so miserable, and I'll do anything, right? Give me the shot. I just want to I'll do it. So.
Okay, we have time for a couple more questions. When would you prescribe an epinephrine auto-injector for someone who has an OAS diagnosis?
That's a great question. So the people who have very severe symptoms and a little bit of some of that overlap, right? We actually get lip swelling, and particularly if their threshold seems to be low, right? So again, we talked about some people can eat 1 or 2 almonds, but if they eat a whole bowl, then they get the itching of the mouth. So if somebody seems to be like even reacting to an accidental sip of a juice, let's say, and they get really impressive symptoms that you're just like, I'm not in my comfort zone anymore. Those are the people that I say, you know what, you probably don't need this, but it's a cheap insurance policy, and let's just have it just in case. Some people with severely severe GI symptoms want to have one because we know that'll work faster than anything else to stop mast cells from degranulating and settle things down. But very few patients, like I'd say no more than 1% of all of my patients with OAS have required me to, have I felt that they actually needed an epinephrine auto-injector. Okay. So it's the minority for sure.
Great. Okay, 2 more questions. We had a question coming in around food sensitivity tests and some of the tests that you might be able to get to help you, blood tests to assess your food sensitivity. Can you give us your perspective on that?
Absolutely, and we have a CSACI position statement about that as well, and I'm sure Jennifer probably has it on her speed dial just like I do. So the IgG tests are what we think of as these food sensitivity tests. So forming an IgE antibody is what causes potentially a food allergy. And that's an abnormal reaction immune reaction to an innocuous substance, right? So the normal response isn't to form IgE antibodies against milk, for example. That's most people should be able to tolerate milk just fine. Some people form IgE antibodies and now they're allergic to it and they're at risk for allergic reactions. Everybody on this call has IgG antibodies to milk. I do, you do, because it's non-human. So the normal immune response is to form IgG antibodies to anything you have consumed that is not human. It's not self, is the way we talk about it in immune terms, right? So measuring levels of IgG antibodies to milk, wheat, gluten, fill in the blank that you get on those tests that you can either pick up yourself from Rexall or a naturopath usually recommends it, doesn't tell you anything. And it's never been shown to correlate with clinical symptoms or clinical disease. So all it is a side effect to your wallet, and definitely causes huge problems down the line when people actually try to avoid this massive list of foods that are in their red zones because they have a really high IgG titer to milk, for example. It's a reflection of what you've eaten over the course of your life. That's what IgG testing does.
Okay, terrific. That was very clear. One last question, and it's been an absolute delight to not talk about COVID for the last hour, but we do need to talk about COVID. And the question is, if you have oral allergy syndrome or pollen food syndrome, what's the safety of the COVID-19 vaccine?
Exactly the same safety as it is for anybody who doesn't have OAS. So just like severe food allergy is not a contraindication to receiving the COVID-19 vaccine, neither is oral allergy syndrome, nor is having a drug allergy, nor is having had an allergic reaction to an unrelated vaccine, nor is having had an allergic reaction to radiocontrast media or IVP dye, for example. So there's very few reasons to not get the COVID-19 vaccine. And again, the CSACI website actually has, if you click on COVID-19 resources, there's a frequently asked questions box that's directed for patients. And you can scroll through and see, basically, there's very, very, very few reasons to not get a COVID-19 vaccine and very few reasons that you'd have to see somebody like me first before you got it.
Awesome. Well, Dr. Ellis, we so appreciate your time and attention today. I've got a couple of things that I need to wrap up here, but we do very much appreciate you bringing your expertise to our audience. It was a webinar that had an awful lot of interest, and we, of course, want people to fill out a survey that will come to you shortly after the GoToWebinar session is finished, and it'll pop up on your screen. So please fill out that survey. You'll also receive that survey via email in the next hour, and please complete it because it's crucial to us understanding kind of what future webinars should be. And also, I know we weren't able to get to everybody's question today, but we would like to make sure that you give us your feedback on what things related to oral allergy syndrome that you would like. So thank you, Dr. Ellis. A couple of other things. Food Allergy Awareness Month is in the month of May. And we do have some more webinars coming up. There's one on May 4th around preventing anaphylaxis in those with food allergy. Is it possible? Dr. Manel Jordana is a scientist and a real expert out of McMaster University, and this is really getting into the basic science behind food allergy. And so put your kind of academic hat on and please join us for that one, because it really gives us a perspective around the basic mechanisms and what's possible in the future when it comes to therapy. On the 19th of May, we are delighted to have Dr. Wade Watson, who's also going to conduct a webinar, and the topic for that one is epinephrine first and the role of Benadryl. We'll hear some of the same messages I would expect that Dr. Ellis has shared with us when it comes to Benadryl. But again, that's about helping people build their confidence of when to, recognizing signs and symptoms of anaphylaxis, knowing it, and then treating it. So we're excited about those things coming up. I'd like to take a moment to thank our sponsors for today. As you may be aware, Food Allergy Canada is a not-for-profit organization, and we rely on the donations for the support of the work that we do. And so if you can consider a donation to our organization, we would greatly, greatly appreciate that. You can visit foodallergycanada.ca/donate to learn a little bit more about the impact your donations make. And today's session We are grateful to the Walter and Maria Schroeder Foundation, the Sean Delaney Memorial Golf Classic, EpiPen, and the Peanut Bureau of Canada, who have provided ongoing funding and support of our webinar series. So at that concludes today's webinar. There will be a recording of this webinar at foodallergycanada.ca shortly. So please share that with others who you think may benefit from the content. That concludes our webinar. Thank you.
Thanks everyone for coming.